Hello and welcome to our August meeting for the Rural HPV Vaccination Learning Community on behalf of the American Cancer Society and the American Cancer Society HPV Vaccination Roundtable. I want to thank you for taking time out of your busy schedule to join us today. And we will be offering live CME and CNE credits for today's session. Today, we'll be discussing the second session of our summer HPV communications series, where we'll be talking through vaccine hesitancy. Next, oh, no, this slide. I'm Christina Turpin. I'm a director for the ACS National HPV Vaccination Roundtable, and I have the pleasure of talking with you first today, but I'm a part of a larger ACS team that's helping out today. So we'll also be joined by Hannah Nine, helping on the back, Brianna Saleh, you'll see her adding things to the chat, Kayla Momzalitze, and Ashley Locke, who you'll hear from later. Next slide. At the American Cancer Society, we love a good icebreaker. So in chats, I would love for you to put in your name, organization, and who in your community, such as a school, faith leader, local influencer, could help spread accurate info about HPV vaccine. And while you're doing that, next slide, I'm going to go through a few agenda items and reminders. So in just a minute, you're going to hear from Steph Gahar, a rural cancer survivor, and then we will hear from Dr. Charnel Valentine on vaccine hesitancy, followed by a panel discussion. So you'll have a chance to get your questions answered in our panel discussion. I do want to remind you of a few things. All rural HPV vaccination learning community sessions are recorded and posted to a public-facing website, which we will go through as well at the end. So if you don't want your image recorded, please turn off your camera. This session is certified for live CME and CNE credit. We have added a link to the chat detailing out CME information for today's session. I do want to note that none of the planners or speakers for today's session have anything to disclose. And we ask all participants to stay muted until our panel discussion. However, the Zoom chat will be open for questions and support throughout the session. Next slide. So today we're focusing on two main learning objectives. Discuss evidence-based communication strategies to effectively discuss the HPV vaccine with different audiences, including parents, adolescents, and healthcare professionals, and address common myths and misconceptions surrounding the HPV vaccine to improve vaccine acceptance and uptake. I'm just going to look through some of your answers here in the chat. Looks like we have a lot of people from Nebraska, New York joining. And don't forget to add into chat who you use in your community to help amplify accurate HPV information. I know a lot of these sessions, people put ideas in that we can use and steal and share and think about. So it's really helpful when we add things in the chat for conversation. And now I would like to go ahead and introduce our first speaker today. So I'm going to introduce Stephanie Gayhart. Steph is a registered nurse, entrepreneur, and young adult head and neck cancer survivor. We're going to add her full bio to the chat as a way to connect with her online. And welcome, Steph.
Thank you so much. I am so excited to be here. Good afternoon, everybody. There is a lot of people here, which is awesome. I want to thank Ashley for inviting me to share my story today, and Eileen from the Head and Neck Cancer Alliance for giving us the chance to do this, for introducing us. As we begin today, I want to take you on a quick journey back in time, before COVID turned everybody's world upside down, to a time when my world turned upside down. Next slide, please. One more. In the summer of 2019, I was 37 years old. I was working in my 8th year as a critical care nurse, and my son had just completed kindergarten. In that June, I noticed a small hard lump under my chin, and I didn't really think a whole lot of it until I began to notice some pain when I swallowed. So I looked in the mirror one night and I noticed this large mass on my tongue back by my left molar. I went to a dental practice and I saw two dentists who treated me with topical steroids and oral antibiotics and assured me that the one thing that we probably did not have to worry about was cancer due to my age, lack of any tobacco history, lack of heavy drinking. But because of where it was, they weren't really able to access it, so they sent me to a local ENT. He again told me that it probably wasn't cancer. I was too young, wasn't really anything to worry about, and gave me a pack of oral steroids and told me to come back in 2 weeks. However, this was now mid-July, and by this time I was in so much pain that I was taking 800 milligrams of ibuprofen 2 to 3 times a day just to function at work and at home and eat and drink. I went back and I told him very directly that if we did not get a scan and figure out what was going on, regardless of what it was, that I was going to kill my kidneys. So he gave me the referral. And when the results came in, he again assured me that even though the report said cannot rule out neoplasm, it was very unlikely to be cancer. He sent me to a practice in downtown Baltimore. Next slide, please. I met my surgical ENT, Dr. Hatton, on August 5th, 2019. I felt immediately at ease with his presence because he saw me as a human first, not a patient. Before we took the biopsy, he told me he was pretty sure I had cancer and gave me directions to get another stat CT of my chest, send a copy overnight of my previous CT, and we set a date for surgery on August 27th. He said if it wasn't cancer, we could high five and come up with a new plan, which I thought was pretty cool. I did everything I was told, and while I was in charge at work on August 7th, at 8 a.m., my phone rang, and it was him. I walked back to the break room, and I remember staring out the window over at the farm museum where I live and hearing the words that the biopsy's back, you have squamous cell carcinoma of the tongue. I don't remember anything else we talked about during that conversation because time seemed to stop. My mind blocked out every overwhelming emotion that threatened to wash over me, and I went into complete business mode. I texted my boss telling her I was going to need a little time off. I called my parents to let them know. I made a post on social media for all my friends and family, and I let the committee leaders at work know that I was going to be missing a couple meetings. I had no idea of knowing then, but when the shift coordinator came to tell me that I could go home for the day, it was the last time that I would ever walk off the unit as a bedside nurse. Over the next few weeks, I got all my affairs in order, figured out short-term disability, went to numerous medical appointments, and attended parties my friends and coworkers threw for me. I asked a coworker who was a photographer on the side to take some pictures of me and my son because I wasn't sure what would happen, and I wanted him to have happy memories of us. I also taught him how to say I love you in sign language in case I was never able to speak again. Next slide, please. So on the morning of August 27th, as planned, my parents and I drove to downtown Baltimore around 5 a.m. to check in for my surgery, which we were told would take between 10 and 20 hours, depending on what they found. I woke up on August 28th to the sound of a respiratory therapist telling me not to fight the ventilator, pushing air through my tracheostomy. I must have dozed back off because the next thing I remember was a nurse telling me I was doing a good job breathing on my own. As I started to wake up and take inventory of my body and my surroundings, I realized I couldn't move my arms because they were either in a wound vac or tied to the bed. I started to panic, wondering how I would call my nurse if I had a problem, if I couldn't speak or move. And it was in that moment that I realized the only control I had over the situation was how I responded to it. I took a couple deep breaths and I managed to calm down. And that lesson hit me again and again over the next week in the surgical AMC. They had removed approximately half of my tongue and replaced it with tissue and vessels from my left arm. They took about 36 lymph nodes from my neck on the left side, and I had drains all over, along with the wound vac on my arm, a feeding tube in my nose, and the tracheostomy. Despite all of that, I healed pretty quickly, and I was able to go home on the same day my son started first grade. While in the hospital, I'd found out that one of the lymph nodes was positive, and because of that, I would also need to prepare for radiation. That was the one thing I didn't want to have happen. But first, I needed to have a second minor surgery to create a skin graft from my leg for my arm. And I also needed to have some wisdom teeth pulled before radiation. But I found time in between all of that to do the color run with my friends in Baltimore after getting permission. I didn't want anybody to pity me. And I kept pushing myself, sometimes probably too much, to prove that this experience wasn't going to define me. Next slide, please. Just around the time I had started getting the hang of eating solid food and speaking with the help of speech therapy, radiation took all that progress away. Every day, I drove the hour to Baltimore to get strapped to the table with the mask molded over my head and upper chest while they zapped me, and then drove the hour back home until I got too tired and I had to ask family and friends to drive. By the end of October, around week 3, I was in so much pain and having such bad reaction with mucositis that I needed the first of 2 steroid doses to calm it back down. That didn't stop me from dressing up as Radioactive Man from The Simpsons for a Halloween party, though. However, during the final few weeks of radiation, the pain had gotten so bad I couldn't eat or drink even water. I was wearing a fentanyl patch, we upped the dose, and I was taking oral Percocet and ibuprofen as often as I could, and it wasn't enough. But somehow I pushed through despite everything in me screaming to give up, and on November 19th, I finished my cancer treatment. In February of 2020, I had my first PET scan declaring me NED, and I've remained cancer-free since. Next slide, please. The effects from radiation took a while to come down, and I had to continue frequent trips to Baltimore for IV fluids and checkups. Eventually, though, I was able to start eating again, and I slowly became stronger. I even think in Christmas of 2019, I had a full helping of mashed potatoes, and that was thrilling for me. Slowly, I started to feel like myself again, and then COVID put us all in lockdown, and it felt like the rug was pulled right out from under me. But after this experience, I knew a little bit about resilience, and I started to become passionate about cancer survivorship and other aspects of healthcare as I tried to figure out how I could fit into my role as a nurse in a brand new way. This led me to joining multiple advocacy organizations and going back to school, eventually getting a master in healthcare innovation. I also became certified as a trauma-informed coach because I wanted to help others learn how to tap into their inner power and realize they could honor the pain, grieve the past, and continue to live a fulfilling life. I've met many amazing survivors, both online and in person, from all different types of cancer in all different stages, and I continue to push myself to do more. It's been 6 years now, and my life is forever changed as I continue to battle the long-term side effects and the changes that cancer brought to me, both physically, mentally, and emotionally. I wouldn't wish what I went through on my worst enemy, but I'm grateful for the person I've become in spite of, and perhaps in some way because of this experience. Thank you.
Thank you, Steph, for sharing your story with us. That was powerful and real, and you're getting lots of hearts and love in on the screen. So I hope you're looking at that. And Steph will be a part of the panel if you have questions and want to react, but keep sending the love because that was a incredibly impactful story. Thank you for sharing, Steph. And now I would like to introduce Dr. Charnel Valentine. Dr. Valentine is a general pediatrician at Essentia Health in Duluth, Minnesota. We will add her full bio to the chat as a way to connect with Dr. Valentine, and welcome Dr. Valentine.
Thank you. You guys can hear me well? Excellent. And thanks for Steph for kind of explaining the reason why we're here today and why this is so important to us. All right. Trying to advance the slides. Okay, today we'll discuss tools for vaccine hesitancy, and a special thanks goes out to the Center of Immunization Research and Education, which is part of the NDSU, North Dakota State University's Center of or School of Public Health. They created these slides, and this is a abridged version of the presentation that I've given for Siri about 8 times throughout Minnesota and Wisconsin. So special thanks to them. And they have wonderful resources that will be linked in the resource section of the talk. I have nothing financial to disclose. All right, objectives of today's talk is to discuss the history of vaccine hesitancy in general and to analyze strategies for addressing vaccine hesitancy and hopefully improve your confidence and comfort in addressing common HPV vaccine concerns. So this is a take-home slide, and just take a look at these numbers. The first group of numbers, talks about cases prior to vaccination. You can see that we used to have 530,000 cases every year in the United States of measles. And post-vaccination, as of 2024, 266. So these numbers are amazing. And in some ways, vaccines are a victim of their own success, in that many parents haven't seen vaccine preventable illnesses. And it's just a good reminder, such a powerful slide. So the World Health Organization back in 2019 identified the top 10 threats to global health, and vaccine hesitancy was on there. And this is a neat slide. This is a Gallup poll from 2024 asking parents, how important is it that parents get their child vaccinated? And unfortunately, you'll see the trend is going down. Back in 2001, over 90% of patients said it was either extremely important or very important, and now that level's down to 69%. And this is telling as well, do you think vaccines are more dangerous than the diseases they are designed to prevent or not? And up to 20% of parents in this Gallup poll said, yes, vaccines are more dangerous than the diseases. So where are we at with our adolescent series? You can see that we've got tetanus in yellow and Menactra in green, and we're doing pretty well historically at about 85% of our teens in the United States receiving these vaccines. And here's where we're at with HPV, and that's why we're here. We've got the pink line having greater than, or having one vaccine, and the purple line being up to date in their vaccine series. So no longer can we, couple or bundle HPV in with tetanus and meningitis, and hope all is well that when they get those other vaccines, they'll add on HPV. We know that that strategy doesn't work. And there are many reasons, yeah, that a provider may be hesitant in addressing, or may find a little bit of discomfort in addressing HPV vaccine hesitancy. You can see from the green line that when a parent answers that, I'm not sure, or I don't want it because of my personal beliefs or religious beliefs, the providers in the study showed that they weren't really confident in addressing that, versus if the question was, hey, it's not mandatory for school, or my child's not sexually active, or we don't believe it's safe. We did a little bit better job explaining that. So the majority of the talk today will be discussing a communication strategy to address vaccine hesitancy with an emphasis on motivational interviewing. So you can see on the left-hand side that on this continuum here, that most of our patients have a high motivation to act and a low resistance to receiving the vaccine. So thank goodness, because you can imagine our clinic day if a majority of folks were either on the fence or against vaccines. So thank goodness we live in the green zone most of the time. But we're here today to talk about what happens in the red zone and in the yellow zone. This is probably the biggest take-home slide. So if your clinic team members aren't doing this already, this is a really important thing to do. We know that a presumptive announcement of HPV vaccine is extremely important versus a participatory. So I see that Michael is 11. That means he's due for vaccines against meningitis, HPV, and whooping cough, versus are we doing shots today? And so studies show that we have a 10 times greater uptake for vaccines getting into arms when our clinical staff, as well as ourselves, make a presumptive announcement of vaccination. And this study kind of elicits that there were 17,000 children in this study over 29 clinics, and you can see that the presumptive announcement was a lot more effective than a participatory announcement. So what are the advantages of presumptive method? Well, it works. It's faster. And it's a similar approach to making other medical recommendations that we do. For example, your child has strep throat. I'll prescribe an antibiotic called amoxicillin to treat that versus your child has strep throat. Do you want her to have amoxicillin to treat it? The more confident we are in announcing it, the more confident our patients will be. And this is another strategy we can use. Studies show that when we place the least popular vaccine in the middle of the more accepted vaccines, as we saw on the prior slide, that the uptake is higher. And so this is something you can discuss with your clinical assistant staff as they announce the vaccines to sandwich HPV in the middle of Tdap and meningitis. Okay, here's our continuum again of vaccine hesitancy, and we'll spend our time talking about motivational interviewing now. So many of you in family medicine have probably been using motivational interviewing for quite a while with, you know, smoking cessation or alcohol reduction, et cetera. I've been using motivational interviewing a little bit as I address patients with pediatric patients with obesity, trying to get them to, after, you know, asking permission if I can talk about their weight, I ask them on a scale of 1 to 10 with how worried are they about their weight today, and that gets the conversation started. So I've been using that as a way to kind of increase my confidence in addressing vaccine hesitancy in the exam room as well. So one thing to remember as we approach our families when they're expressing ambivalence, and ambivalence is normal. It's a normal part of the change process. We need to recognize that it's possible to have coexisting feelings that you want the vaccine, but you're a little bit scared or hesitant of it. And we need to honor that in our interactions with families. So communication techniques we can use. We can ask open-ended questions. So when we sense hesitancy or they say they're not doing a particular vaccine, we can mirror that back. Are you sure about HPV vaccine, or you aren't sure about HPV vaccine today? What worries you? And then reflect back what you're hearing, and restate, ask permission if you can share more information with them. And then, of course, end with a strong recommendation and support their autonomy that you've heard them, and ask if you can address it again in the future if they're not going to get the vaccine today. So I've alluded to scaling questions earlier when I talked about pediatric obesity. So you can use this with anything you're trying to get to the bottom of on a scale of 1 to 10. How important is it for you to get the vaccine today? And then if they say a number like 5, you could ask them, well, what makes you not a 3 or a 4? And what can we do to get you to a 6? And that's going to be a kind of a displayed in the clinical vignette that we're going to go over soon. Here it is. So I'll be the doc, and I think Ashley is going to be the parent in this scenario. So hi, Diego. Great to see you, Lenny. I see we're in for a well child check today. Provider looks at Dad, Lenny, and says, as part of today's visit, great news. We can, sorry, I guess Lenny's the child, sorry. As part of today's visit, great news. We can protect you against flu and HPV and start the HPV series. Dad, any questions?
In my best voice. Wow, HPV, isn't he a bit young for that vaccine? He's only 9.
That's a great question, and I have heard that before. Can you tell me, or can I tell you more about why we should consider vaccination at age 9?
Sure.
Okay, so that's the question. And now we're just going to take a step back, and we're going to try to get the facts straight in our head, and hopefully over time you'll come up with your own statistics based on some of this research that you'll see presented. So you'll have an answer of why 9 ready to go in your head. So please remember the this iceberg analogy. You can see that cervical cancer is 11,000 cases a year. Now we've got almost 200,000 cases of pre-cervical or cervical precancers. But then the other causes of the other cancers that HPV cause are listed there as well. So other cancers of the genitals as well as head and neck cancers. And to remember the statistic that 90% of HPV related cancers are preventable with vaccination. So that's our background information. We've got in a brief that was came out in 2024 in the Journal of Clinical Oncology. We know that this is real world statistics at 54% lower odds of boys developing head and neck cancer and 30% lower odds of developing HPV related cancers in females. And this is a really neat study. I remember driving into work and listening to NPR when I heard about this last winter. And so what you'll see on the orange line is the predicted deaths associated with cervical cancer in young women 25 years old and younger. And you can see with the dotted line the reduction. And what happened around 2013, that was HPV vaccine coming on board. So we can say that there's a 62% reduction in cervical cancer deaths in women under the age of 25. So the take-home message, just like putting on a bike helmet before you go to ride a bike to protect against serious head injury, HPV vaccine is incredibly effective if given before exposure to the virus. So we're back to the vignette. So the answer to why age 9, we could say we started HPV vaccine around age 9 because this vaccine is really about cancer prevention, protecting Lenny long before he'll have contact with the virus. Starting Lenny now also means he'll be more likely to finish the series and provide that protection that he needs. What stands out to you about what I've shared?
So I appreciate the information. I guess my biggest concern is that my wife and I didn't think about starting the HPV this early. We haven't really prepped Lenny for it today.
I appreciate hearing your concerns. On a scale of 1 to 10, how confident are you in vaccinating Lenny against HPV today?
Maybe only a 5.
Great, you said a 5. Why aren't you a 2 or 3?
I guess because I do want Lenny protected from things like cancer, but like I said, we haven't really prepped him for it today.
I hear what you're saying. Is there anything that I could say to get you to a 6 or 7 today?
I guess more details on why Lenny really needs it now versus 11 or 12.
Absolutely. Mind if I give you some additional details?
Sure.
Thank you. We know that giving this vaccine at 9 or 10 produces a stronger protection than giving it later in adolescence. Also, if we start this before 15, Lenny only needs 2 shots to be up to date. This means less shots at his 11-year checkup. What would you like to do? I highly recommend HPV vaccine to my patients and recommend that we get Lenny started today.
Okay, let's do it.
All right, I'll send in the nurse. Excellent. So thanks for that. And we'll go on to a different motivational interviewing technique other than the scaling questions. This is elicit, provide, and elicit. So like I shared before, we're going to start with eliciting and asking open-ended questions. So if somebody's expressing vaccine hesitancy or refusal, we should really try to understand exactly where they're coming from before we give them counseling. So what specific concerns do they have? What have they heard? What would they like to know? And then we ask permission and we can say things like, this may not fit for you, but some people find, or may I make a suggestion? And then we listen to their response and we reflect on it, and then ask them what they think about what we talked about today, and if they're ready to give the vaccine. So for example, if we hear, for example, with varicella vaccine, I don't want my child to get a chickenpox vaccine today. We really don't know what that means unless we elicit a little bit more. It could mean my child has already had chickenpox, or I don't think chickenpox is that big of a deal, or I'm pregnant and I'm not sure about my child getting a live vaccine. Here's another vignette. I'll start it out again. Great to see you, Julie and Carly. I see Carly is due for a sports physical. As part of today's visit, Carly is due for her Tdap, HPV, and meningococcal vaccines. Any questions?
I'm not sure about Carly getting the HPV vaccine.
Thanks for letting me know. Could you tell me a little bit more about your concern?
So thanks for asking. So I've done some research online and I'm worried about how safe it is. I read it may cause something called POI, which could impact Carly's ability to have kids.
I've heard that before. May I share some information with you?
Absolutely.
So this is our pause. This is where we're going to review the facts in our heads so that we can have a confident response. So I think the thing that stands out to me is HPV vaccine has been around for over 15 years, that it had large clinical trials. Over 15,000 men and women were studied in the original trial, and over 130 million doses of HPV have been given. And we've got 160 plus studies on HPV vaccine around the world with a favorable safety profile. And we do continue to monitor HPV safety in systems like VAERS and the Vaccine Safety Data Link. And we should acknowledge the common side effects of HPV vaccine, pain, redness, swelling, and putting it into perspective, HPV vaccine is cancer prevention. So with these facts in our head, we can also review specifically what POI is. Why this myth keeps going around, it's because of social media. What happened is that there was a case study followed by an additional 5 case studies that tried to link an adolescent with premature ovarian insufficiency or premature menopause in relationship to them receiving HPV vaccine. So the anecdotal case study gained a lot of attention that did not kind of match up with its scientific rigor. And so how has the CDC and the FDA addressed the concerns that HPV might be causing infertility? Well, it's continued to be monitored, and let's look at the research. So this is a quote from the director of the CDC. They've got 12 years of studying HPV vaccine safety, and a 2018 study that looked at over 200,000 American women did not find an increased risk of premature ovarian insufficiency following HPV vaccine. And then beyond what the U.S. has done, this is a study in Denmark looking at over 1 million women, and no association was found between HPV vaccine and primary ovarian insufficiency. So we've got 2018, 200,000 U.S. women were looked at, and then in 2021, over 1 million Danish women. So to respond, I could say HPV vaccine has been around for a long time, over 15 years. And during this time, there's been over 100 million doses of HPV vaccine given in the United States. We have very promising and reassuring data that these vaccines provide long-lasting protection against cancer and that they're very safe. The rumor that this vaccine causes infertility still makes its round on social media. But as part of ongoing safety monitoring, the US has looked at over 200,000 women, and Denmark has looked at over 1 million women and have found no link between HPV vaccine and infertility. Sorry for that typo there. Should be 1,000,000. So some of my patients do experience soreness, redness where the shot was given, but it's common and that'll get better in a day or two. And I want you to know what is absolutely linked to infertility is HPV cancers. The fact that they can cause HPV cancers can cause, uh, you know, issues with your child having infertility is well known in the medical world. I vaccinated my own daughter against HPV, and I would highly recommend that Carly get vaccinated too. What stands out about what I've shared with you?
No, that makes sense. And I guess I hadn't really realized that HPV vaccination had been around that long. I really appreciate you taking the time to talk to us about it. Your recommendations are very important to us, but I think we're going to take some time to think about it.
Of course, may I send some resources home with you? I think HPV vaccination is an important part of keeping Carly healthy. Could we address this at her next appointment?
Absolutely.
Great. Well, thanks for bearing with us for those clinical vignettes. Hopefully, your mind is going to be filled with statistics and ways that you'll be able to script and answer those questions when you have it in clinic. This is a resource that I've made for my own clinic. Many of you, well, we're all required to have the VISs in the room where we either give paper copies or in our clinic, we have a laminated sheet of QR codes with the VIS. So what I've done with this is collect QR codes from CHOP, Children's Hospital of Philadelphia, which has a vaccine fact sheet on each of the vaccines that we give, and HPV is listed on this as well. And for those families who are hesitant on most vaccines or all vaccines, I really think it's important to get CHOP's app in their hands. And so I really encourage them to download the Vaccine on the Go app. And that is an extremely powerful app from CHOP that goes over every vaccine, every fact sheet, tons of resources. So I have it on my own phone, and it's a neat thing to review. And moving on. Oh, yes. Ashley has let me know that my last couple slides have been put into the resource section. Those have to do with webinars that you could take on motivational interviewing techniques. I've done them through the NDSU's Siri. As I mentioned before, they're excellent. So if you want to take a deep dive into that, there's also a general webinar on HPV, disease and the HPV vaccine. So. With that, I'll be part of the panel. Thank you very much for your attention.
Perfect. Thank you, Dr. Valentine. So we are going to go into a panel, and some of my colleagues are just being added in here shortly. So I do want to welcome Dr. Valentine, Steph Gahart, Jocelyn Phillips, and Dr. Young to our panel discussion. I know Jocelyn and Dr. Young, you guys are just getting started with us. So want to give each of you a chance to just introduce yourself and share how your work has, how your work as experts in motivational interviewing connects to HPV vaccination. So I will go ahead and let Jocelyn go first and then Dr. Young.
Thanks, Ashley. My name is Jocelyn Phillips, and I work for the American Cancer Society. I have for about 18 years. I'm based in Nashville, Tennessee, and I'm here today, and I'm really honored to be invited, so thank you. I'm here today because I'm trained in motivational interviewing, and for the past few years, I've done a lot of work training primary care practices and federally qualified health centers and people that work in those clinics around motivational interviewing. And it hasn't necessarily always been about vaccine hesitancy, around colorectal cancer screening and vaccine hesitancy. It's been really interesting because I've had people in the room all the way from, patient navigator, front desk staff to CMOs of clinics. So it's been really interesting to get their feedback and responses to motivational interviewing, but I think it's such a handy tool, especially when it comes to vaccine hesitancy. So thank you for having me.
Perfect. Thank you, Jocelyn and Dr. Young.
Good afternoon, everyone. Thank you for having me. As mentioned, Dr. Jessica Young. I am a pediatrician and preventive medicine physician at the University of North Carolina at Chapel Hill. And of course, as a pediatrician, I am recommending HPV vaccine to my patients every time I'm in clinic, if they're eligible, and I do recommend starting at age 9. But also for over the past 3 years, I've done a lot of work in the HPV vaccine space, particularly in research looking at vaccine communication. Dr. Valentine shared some of the work that I've been a part of with Dr. Norburu, who is also here at the University of North Carolina at Chapel Hill. And in that space, I've done a lot of teaching over the country to a lot of different healthcare providers, doctors, nurse practitioners, physician assistants, nurses. I've even had the pleasure of working with some dentists and dental hygienists before, to talk about how to effectively recommend HPV vaccines using evidence-based approaches. And part of that has been teaching people how to use the announcement approach, which, as Dr. Valentine highlighted earlier, highlights the importance of using a presumptive approach when recommending HPV vaccines. And as a part of that teaching, we do a lot of teaching on how to, again, communicate the vaccines, why we think is important, but also we use a lot of those communication techniques, really draws from the motivational interviewing techniques as well. And so we practice and teach a lot of the reflective listening and really understanding how to build that rapport and welcoming environment with parents. So again, I'm happy to be here and happy to answer questions that you all may have today.
Perfect. Thank you both for introducing yourselves. So we did have a question come into the chat, and I think that this is a really great one around training staff. And so I'd love to throw this one to Dr. Valentine and to Dr. Young so you guys can share from your own health systems. But how do you better equip staff to address vaccine myths confidently and compassionately? So I'll start with Dr. Valentine and then go to Dr. Young.
All right. Well, I sure welcome my staff to do the presumptive approach. As they're rooming, one of the first things that the kids and the parents want to know are there vaccines today? And I even started at age 8, giving them a heads up that there's no vaccines today unless it's flu season. But at age 9, we'll start with your vaccine to prevent cancer. And I leave it at there. And if they have any questions, they can sure bring it up at the moment. But I start there. And then my staff specifically, they'll make an announcement approach. It's like, oh, you're 9 today, so you're due for one vaccine against cancer. I'll pend it for Dr. Valentine. If you have any questions, she's going to talk to you about it today. And yeah.
And I'll say providing a lot of that foundational knowledge that Dr. Valentine shared with us too, about HPV and what it can cause, but also HPV vaccination, I found has been really key. I think overall people just want to feel really prepared to answer those common questions or myths that might come up. And so making sure that people have that knowledge about those evidence-based approaches, and again, about the disease processes that can occur. And why we recommend HPV vaccination really helps people to feel more comfortable addressing any myths that might come up. And I've also found that, people don't need you to also necessarily go into super nitty-gritty details about, studies that have been done, but to just kind of have those key takeaway points will really go a long way. And just to also reiterate earlier, as we talked about too, people will kind of hang on to those words that you say if you're confident about what you're saying. And so just helping people to feel more confident in providing those recommendations or just talking about HPV vaccines, I've found has been really helpful for staff and providers as well.
Perfect. Those are really great tips. My next question, I think I'm going to throw this first to Steph and then would love to hear also from one of our physicians. But Steph, as a cancer survivor and a rural cancer survivor, can you think of a time when you have had a conversation with someone about the HPV vaccine and been able to maybe reconsider their views and what kind of made that shift possible? So I'll throw it to Steph and then Dr. Valentine or Dr. Young, if you'd like to address it as well.
Yeah, I actually brought this up recently, I helped run a support group for queer cancer survivors called Cheeky Charity, which is mainly colorectal and anal cancers, but we brought up the topic of HPV and the vaccine, and there was a lot of questions around the age and things like that, and a lot of misinformation. And I think probably the best thing that I have learned to do is to, even with my knowledge as a nurse, try to remember to stay curious instead of judging and jumping to conclusions about why I think people have this idea, and just listen to what they have, sort of exactly like we've been talking about today. And a lot of times that really leads the conversation in a much more positive direction and keeps the conversation open. So it's more of a general, example, but it works.
Perfect. And then Dr. Ng or Dr. Valentine, I don't know if you want to share a time that you've been able to have a conversation with a parent and maybe change their perspective.
Yeah, I'm happy to share. I've had plenty. One of my most recent conversations was about a parent who was concerned. Again, I recommend HPV vaccine starting as early as age 9. So I had a parent concerned about it being too young for her child to receive the vaccine, and sex gets brought up a lot, and so that parent also brought up, my child is nowhere near being sexually active. This is not something that my child needs at this time. And so I think what really helped to kind of shift the conversation is I didn't, as Steph just mentioned, kind of jump in a judgmental way. I allowed her the opportunity to express her concerns. I validated her concerns, used a lot of those kind of reflective listening, summarizing what I've heard. And after I kind of gave her that space to, air out all of her concerns, I asked for permission to address the things that she said. And so I tried to make sure I kept it focused on her specific concerns and not necessarily bring up other information that was not really related to her concerns. So she was concerned about her child being too young and her child not yet being sexually active. So I didn't really go into a lot of details about, safety of the vaccines or why schools don't require it and some of the other concerns that often come up, but made sure to keep it specific to her concerns. And then, thankfully at the end of that visit, because, she was able to feel more relaxed and felt that she could trust my opinion, because again, if you approach it in a confident way, I think that can in itself help to dispel a lot of the concerns that parents might have. But at the end of the visit, she did a complete 180 and was ready to get the vaccine that day. So I think just providing that kind of space for her to feel open to talk about her concerns really went a long way, even though she came in with a lot of concerns about the vaccine in the beginning.
Perfect. It sounds like you used a lot of motivational interviewing, which is great. I'm going to ask Jocelyn this one, but what guidance would you give to someone who maybe just start using motivational interviewing techniques and tactics when they're having vaccine conversations?
Thank you, Ashley. I think Dr. Young summed up a lot of that. It's confidence, asking questions, motivational interviewing. If you look at all the content or if you take a training, it can seem very complicated, but it's really not. It's a way of being rather doing. I think it might have been Dr. Young or Dr. Valentine who said, stay curious. Or no, it was Steph, stay curious. Ask them what their motivation is. Can I tell you more about it? But be confident. And if you're not confident in all of the facts around HPV, have a one pager to give people. Have just one or two facts that you fall back on. And interestingly, and I'm a mother, not only do I work for the ACS, but I'm a parent. And I've had this conversation with some of my friend groups where they have been concerned about the sexual component. And I remind them, your infant was vaccinated for hepatitis B. That can be a sexually transmitted disease. That happens when they're a baby. And it kind of took the air out of the balloon. They were like, oh. So just reiterating that it is safe and effective, and asking questions, which Dr. Valentine described so nicely in her presentation, like, why are you concerned? Can we talk about that more? Can I give you some more information?
Perfect.
I just have another resource to add. It isn't really specific with HPV, but it's such a wonderful resource. I want to make sure that everybody knows about this resource from the Immunize Kansas Coalition. It's called Vaccine Fears Overturned by Facts. And if we could put that in our chat, if that's possible, because my story has to do with a vaccinated 6-month-old baby. And when they came back for their 9-month, unfortunately, mom's friend group and Facebook site, she kind of went down an echo chamber of anti-vax, and she was willing to then no longer vaccinate. And because I found this resource and I printed it out for my own sake, it was probably 40 pages, color copy, just beautiful. I gave it to her. I put it in her hands, and at the next time she was ready to go forth with a typical immunization schedule. So, you don't forget those wins, and it kind of powers you for all the other conversations that you have. And one of the things I'd like to reiterate, this comes from some of the other Minnesota, you know, uh, vaccination experts, is to get comfortable with the pause. When you ask the question about what makes a parent pause when considering a vaccine, we need to be comfortable with the pause. Because we just need to have them be thoughtful and be able to tell us what's going on so we can address their concern and not overwhelm them with a lot of information, statistics, and because we know that very, very anti-vax people, the more information you give them, it actually entrenches them more. And we're not trying to make it worse than when they walk through the door. So find out where they're coming from and adjust, right? The pivot MI, right? Assume, and then if you see hesitancy, you pivot to motivational interviewing. And yeah, I really appreciate everybody's thoughtful responses today. And Steph, thank you so much for your story. That was unforgettable.
That is really great advice, Dr. Valentine. I like that you talked about becoming comfortable with silence and the pause. And I really like that you referenced a tool and a resource. And actually, that was going to be my next question for everyone. But looking back, are there any tools or resources that you wish you had tackling HPV vaccination myths or HPV communication? And if so, would you share them, and what would be most helpful, I guess, now thinking? So let's go ahead and start with Dr. Young, and then we'll go to Jocelyn and Steph.
Yeah, I guess I'll start with the not so traditional kind of resource. It's not really a tool or resource that you might think about. But before I started kind of my work in HPV vaccine communication and teaching others how to effectively recommend the vaccine, I didn't really realize how powerful it could be to let parents know, parents who declined the vaccine at that current visit, to let them know that you would bring it up again at the next visit. And I think it kind of just sets a precedent, sets a tone that, reinforcing that this is very important for your child and this is how much I believe in it, so much so that we are going to talk about it again. I want you to come back with additional questions. I found it to be a really powerful tool, and it helps parents to really anticipate kind of what might come up in the next visit. So they know that you're going to bring that up again. They might hopefully will feel more ready or at least more equipped with questions and to have an open dialogue and discussion about the vaccine. And then for more kind of traditional resources, the clinic where I work, we did a big HPV vaccine quality improvement project last year. And we did lots of different things. But one thing that I found really helpful was to have some handouts and flyers available, both through the American Cancer Society. So thank you all for those handouts, and also the American Academy of Pediatrics. And just having them available in each of the exam rooms we thought were really helpful, because not only did it help parents and families to kind of absorb that information in a different way that kind of went along and along with our verbal recommendations, but it also helped us as people recommending the vaccines, because again, it can be hard to remember like the statistics and the numbers. And so having that readily available in the exam room was actually good for the parents and families, but also for us to kind of have a quick reference as well.
Perfect. Thank you for sharing those with us. Jocelyn and then Steph.
One of the documents that you might have used is one of my favorites. And I think it's still called this. It's called Just the Facts, and it's a one-page sheet that's co-branded, I think, with the ACS and the roundtable. And I love that sheet. It's a great takeaway, and like you said, it's a good reference to have yourself. But just remember that a strong provider recommendation is the largest indicator of a child getting vaccinated. So keep doing the good work, everybody. Thanks, Ashley.
Perfect. And then Steph.
Yeah, well, actually, this is more of a, my personal what I wish I would have had. I was in my 20s when the vaccine came out. And at the time I was already told, well, you're too old, you've already aged out, this isn't for you. And that has changed over the years. And even now, I happen to get an email from Medscape or something, one of the things I'm, subscribed to, that went over the studies that even people who have already had dysplasia, cervical dysplasia, if they get a dose of the HPV vaccine, can decrease the recurrence of the dysplasia. I believe I'm saying that correctly, but knowing those things and not having that education is extremely important to me. So, obviously I had my son vaccinated, even though we can't definitely say that my cancer was or was not. It was P16 negative, but who knows if we find out more down the road. I still would like to know that there are things that I can still protect myself from, even though I'm 43 years old. And it's important to have that information even for people at my age, is basically what I'm trying to say.
Perfect. Well, thank you all for participating in today's panel discussion. You all had really great insights, and I think the biggest thing is, practice makes perfect when it comes to HPV communication. Be a lifelong learner is what I'm taking as well away from it. Be constantly looking for new resources and new studies out there so that you feel equipped to being able to answer questions and parent concerns. But I appreciate all of you for being a part of today's discussion. So we're just going to quickly wrap up and then we will get you all on your way. So as always, we're gonna do a quick poll. We would love to hear what you learned today and what you're gonna take forth as you move forward. So let me go ahead and launch that really quick here. But let us know if you learned anything about vaccine myths, if you learned something new about strategies to overcome vaccine hesitancy, what information was new to you, and if you interact directly with patients, how confident are you in utilizing the strategy shared today? So. Looks like we're slowly getting participation. We appreciate those of you that do participate. It really helps us to make sure that we're meeting our learning objectives and making sure that the content is relevant. So appreciate it. We can move forward and let those continue to take the poll. So we've mentioned this in past calls, but I do want to spotlight it again, and I will continue to. We do have an external facing website built just for all of you. It's the Rural HPV Vaccination Learning Community landing page. It's your go-to hub for everything we've shared throughout all of our sessions. So my colleague Brianna, she is going to drop a link into the chat. So if you haven't bookmarked it, now's a great time to do that. It's a resource that you can come back to again and again. So please make sure to check that out. Next slide. We love resources as much as we love icebreakers, and you can easily access our ever-evolving resource roundup under our important links on that landing page. In fact, I added some new resources to our HPV communications section, including those trainings that Dr. Valentine shared on the announcement approach and vaccine hesitancy. I'm going to be linking a few others based on our panel discussion today. If there's a document that you would like added to this resource, please feel free to email me or chat it in the chat today, and we will make sure to get it added. We're constantly changing and making sure it's up to date. So next slide. So two resources that I do want to point out in today's call is the American Cancer Society has refreshed its HPV vaccination resources for health professionals page, which you can find on cancer.org. That is our main website. And so this is going to make it easier more than ever for providers to access evidence-based tools, our patient education materials, and implementation guides to increase HPV vaccination rates. So that just went live last week. So know that it is available for you and you can feel free to let people know. Next slide. We also have our brand new HPV social media toolkit. I shared it last month, but it's full of ready to use graphics and messages in both English and Spanish, and it can be used for clinics, health systems, and community partners. It's a plug and play, visually engaging, and we actually showcase an image that you can download from that toolkit on this slide. Next slide. So there are lots of calls to action on this particular slide, but as a recap, here are 5 things you can start doing today after participating in today's session. Use strong communication, start with a presumptive approach, and shift to motivational interviewing when needed. Debunk myths, know the common concerns, and respond with facts. Make confident recommendations, offer HPV vaccine at every eligible visit starting at age 9. Be able to educate and empower, share your personal stories, and ask open-ended questions, and use our resources. Bookmark our landing page, check out the roundup, and download our social media toolkit. Next slide. I want to thank you for joining today's session, and we look forward to seeing you on September 10th, where we're going to conclude our communication series with a panel and discussion on using trusted messengers.